So we are continuing with our essentially journey through osteopathic historical material in the form of textual analysis, with the reality that this isn't being done traditionally as a textual analysis. So just to reframe, textual analysis has highly selected texts. Those things are definitely constrained by the individual making the choices, so you can make an argument that others should be included. In this case, I'm letting you know that I've chosen the texts that are included. So we also want to reframe, because we're putting another constraint package on this, which is the concepts of epistemology, ontology, and axiology, aka the three main pillars of the philosophy of science. So we just redefine these things again, or provide the definition so that the rest of this discussion is appropriately led. So epistemology is a theory of knowledge creation. So what can be known, how can it be known, who can it be known by? Your large, well-known epistemologies are positivism, post-positivism, and constructivism. They generally form a proposed spectrum, positivism being one singular reality, regardless of observer. The constructivism is on the other end. Constructivism says that knowledge, or what can be known, depends on the individual, environment of observation, and previous experience. Post-positivism says there is one singular reality, but the ability to identify it depends on the individual doing the looking. Ontology is your classification system. Philosophically, it's the study of reality. Within science, it is how you classify, or the categories that you use to examine what is real. You define each thing on its own merit within a category, and then you're able to compare them. Axiology is the value or values of, usually in science, the researcher. However, in this case, because what we're doing is looking at historical texts, we're identifying the value or values of the people claimed to have written the material. To again frame the beginning of our discussion, we look at the emergent themes so far. So we've looked at Dr. Still's work, and we've looked at Elmer Barber's work. So the emergent themes that seem to be stable between those two works is a lack of a consistent epistemology. What you're seeing quite often, so with Dr. Still you saw multiple epistemologies. With Barber, what you would see more often than not is a positivist claim. So it's a singular reality claim, but it is the way that the knowledge was built was constructivist. So it was dependent on Barber, and there was enough evidence that that's how those knowledge claims were built. So what we see is an unstable epistemology if we consider both of them. Barber's epistemology seems to be a little bit more stable. However, it's unstable between the both of them. So as an emergent theme, we can say that there's no consistent epistemology in early osteopathic writing so far. Ontology, in the case of both Still and Barber, is you're mostly classifying reality, or what's real, based on functional anatomy. So they look at functional anatomy and then they pair that with what they see. So signs and symptoms. Signs in healthcare being those things that somebody outside of the person suffering can identify. Symptoms being those things which the person suffering can identify. So they're classifying those through the lens of functional anatomy, and then they're using that essentially as an expression of the laws of nature, or what's real. Axiology is mostly focused on individual empiricism, so they value their ability to identify things on their own, do their own work. And the general prejudice against other healthcare systems does hold stable. However, Barber seems somewhat softer on other healthcare practices. We also have the emergent theme of high degrees of certainty in objectively uncertain situations. And again, to be fair, contextually, in their time, they may have been making claims that were as certain as they could be with available technology and available knowledge. However, as we look back on it, we can apply today's lens and say that they were quite certain in uncertain terms. So for this portion of the project, or our osteopathic historical project, we're looking at the writings of Charles Hazzard. He was an early graduate. He graduated in 1895, so if I'm not mistaken, he would have graduated with Elmer Barber. He was appointed faculty of the ASO in 1898 as a professor of osteopathy, and he also worked at the AT Still Infirmary, right? So he also had more than one book written. Most of what we're going to look at is his lecture notes from his class when he was teaching at the ASO. As well, we're going to look at one of his books that was co-authored, right? But that's Charles Hazzard. Very, very broadly speaking, very early osteopathic practitioner, early teacher. So what we would expect is that because he was so early on, it's reasonable to expect that the themes will hold stable within his work. So as we've already noted, the material that we're looking at, there's 2 volumes of lecture notes. Lectures on the Principles of Osteopathy by Charles Hazzard, volumes 1 and 2, so that's from 1898 when he started teaching. So these are notes from classes he taught. I've actually, when I've been in Kirksville, had the opportunity to look at printed version of these. They are also available online through Andrew Taylor Still University's website, which links you to the Museum of Osteopathic History, where you can find these PDFs. And we're also going to look at the practice and applied therapeutics of osteopathy. Actually, I made a mistake. I said that the Practice and Applied Therapeutics was co-authored. That's not true. That's Hazzard on his own. I'm thinking forward to another set of texts that we will examine, but as of right now, these 3 really texts are directly from Hazzard. So our first quote comes from the lecture notes. Learn to treat, or general considerations, lecture 1, general considerations. Learn to treat, understandingly imitate no operator's motions. Emerson says imitation is suicide. Take, for instance, a case of erysipelas. I'm probably mispronouncing that. Should the operator treat about the sore spots occurring usually on one side of the face near the ear and treat there alone without giving attention to the general conditions of the patient, taking into account the affections of kidneys, liver, and other organs in this trouble. In this trouble, he would certainly not meet with success. One must understand the nature of the disease which he is treating. So we have in that paragraph 2 themes. Individuality, so the individual empiricism, as well as you have to understand the disease, otherwise you won't know what to do. So this seems to be an early instance of, again, as Barber did, importing disease classifications, but matching them up with functional anatomy. So functional anatomy is the primary ontology. Disease categorizations help for communication. So go back to the quote. Make a correct diagnosis of the case. There are no 2 cases alike. You cannot take for granted that one case which you receive today is like the case which you treated yesterday. Look over the case thoroughly, making an individual diagnosis for it. Likeness and unlikeness to other cases are incidental only. So we'll just pull out there. It's essentially saying be inductive. So observe and then work from observation instead of being deductive or importing things that you've learned before. So he's making the case that individual empiricism is very likely a more appropriate way to interface with the patient because you're paying attention to the patient. As far as developing knowledge, you can make the argument that there are pros and cons for individual empiricism with respect to epistemology. But as far as the individual patient, this seems to hold fairly useful or to be a fairly useful consideration because this seems to also be an early note that osteopathic treatment is not necessarily based on a disease process, it's based on the mechanical side of dysfunction or motion. So you need to pay attention to the motion dysfunctions you can find as opposed to the disease process, which then allows it to make more sense why they use functional anatomy as their primary categorization system. So to go back into it, make no diagnosis by telephone, as I knew a physician, a fellow townsman of mine, to do once, right? So that's just essentially saying, make sure you actually observe the patient. Remember, a young doctor's success often depends upon how he handles a simple case. For instance, headache, which, although not always simple, is frequently so. Right? We're not necessarily going to get a lot more from this portion of the quote, but to jump to the bottom of the quote, have your theories, but stick to facts. Remember that you cannot always treat a case according to preconceived theories, that each case is peculiar to itself. Huxley says theories do not alter facts, and the universe remains unchanged even though texts crumble. So, you have an interesting mix here. So this is an inconsistent epistemology again. It's making a case for positivism that theories do not change facts. So that's positivism. There's an underlying obligate reality that won't change no matter who looks at it. You can think about it however you want, you can interact with it however you want, but it's unchanging. So that's a case for positivism. But he's also talking about paying attention to the individual case. Now, in paying attention to the individual case and building your knowledge that way, that's a call for constructivism. So we have a bit of a mixing of epistemologies here. I'm not going to say that that's a problem, but I'm going to say it's observable. I would suggest that there's something very valuable in paying attention to each case as it presents itself through the primary lens that you're going to work with. As an osteopathic practitioner, the primary lens you're going to work with is that of motion, so motion presence or motion absence, and you're going to work with that. You're going to attempt to interpret that, or at least based on these early writings, attempt to interpret your findings in relation to signs and symptoms through functional anatomy, right? So again, primary theme, individual empiricism, mixed epistemology, and paying attention to the patient, which I would say is highly valuable. So continuing on with lecture notes, the osteopath finds the atlas of great importance to him in his work for the reason that it may impinge upon certain nerves and may affect spinal centers, or it may act in such a way as to deprive the brain of its supply of nutrition, and thus lead to results which are very significant to the osteopath. It may act in such a way as to shut off the blood supply to the brain, and it may affect every center in the brain. Hence, you may commonly find that your patient has been unable to speak for a long time, or has been unable to hear plainly, or he may have become insane. It may also impinge so much that it presses on the cord and robs it of its nutrition, so that there may follow various spinal troubles. Right, so continuing on, the theme of this quote is primarily functional anatomy being your categorization system or your classification system or your ontology. What it's also doing is it's giving you a range of possible changes to function based on mechanical changes, and what you would need to say there is that that's a positivist claim, one individual reality, but it's showing variation in how it will express itself. So saying with any expression of altered function above the head, or above C1, consider the atlas as go to the atlas as your first consideration of causation. So what that would be is deductive. You're importing a concept. Anything I see in the head, as far as change of function, I need to think the atlas. He's also told you previous to this, treat each case as it presents itself, right? So he's told you to be inductive, to observe the case. So you're getting a little bit of confusion as to how to interpret, so how to identify what's going on and then how to interpret it. So if you identify a sign or a symptom, he's saying, think about this. But he's also saying, before you think about that, make sure you check it out, right? So you've got competing ways to develop your knowledge of the patient or how the patient is presenting. So again, inconsistent epistemology. Turning back into the quotes, the osteopath, in thinking of these things, thinks of the normal anatomy of the part. He says, here is a point which may be subjected to strain or twist. It can be extended or shortened to some extent, so that these are movable points. And being points at which a strain may occur are points which are liable to disease. You will find this of great significance in the etiology of spinal curvature. Along this line, I simply want to quote from Halliburton. He says, disease of the spine may begin in the vertebrae or the intervertebral substances. I think of, on the whole, in the intervertebral substances where it is joined to the vertebrae. His editor, Dr. Jacobin, says that his view is supported by the fact that the junction of a more with a less elastic body is the weakest spot and therefore receives the full effect of strain. He instances the case of an etherematous artery. The weakest portion is where the diseased wall joins with the more elastic substance of the healthy wall, and it is at that point where the real strain comes and where an aneurysm is likely to occur. Hence, as I explained, here arises for the osteopath the significance of a distorted vertebrae, causing a slight irritation to the part, storing too much blood and nerve force and life there, and setting up some irritation, causing a thickening of the ligaments and perhaps a permanent injury to certain parts, especially the nerves. So you have an inferred concept that is coming from another knowledge creator, that where you have a less elastic part and a more elastic part, the more elastic part is more able to deal with strain, so the less elastic part is going to show the injury. So if you strain the more elastic part, the less elastic part will show it. That is the rationale for making that claim is not properly discussed here, so you don't know if you can trust that claim. Superficially, it would seem like you can trust that claim. You know, something that can deal, that's more adaptable should be able to deal with change, whereas something that's less adaptable should likely show more problems. He then imports that concept and maps it over to something with respect to the vertebrae and saying, because the vertebrae has a more adaptable part and a less adaptable part, we see this irritation, right? So that's essentially interpretivism, right? So you'd call it on the end of constructivism. So he's making a positivist claim, making a rational argument. If I can think it, therefore it must be true. So this person said it about this thing, so it must be true about this other thing. Unfortunately, if you're working through a positivist lens, what you're often going to find is that things that occur that you would think are rational are often don't occur, and what does occur is quite counterintuitive, which is why you have to investigate it properly. So he's essentially making an interpretivist argument. He's interpreting something else to mean a thing that is not stated. So again, inconsistent epistemology, also heavy reliance on functional anatomy to classify reality. So continuing with quotes from the lecture notes, I have thus taken up the grouping of the nerves along the spine. Of course, it has been very general. The purpose has been to give you a general view of regions affected and to give you a general idea of how the osteopath looks at disease. That is, he reasons from periphery back to center. My treatment of the subject has necessarily been general, leaving aside more particular view until such time as we shall take up these different affections which we meet more in detail. I may, in these last few lectures, have been a trifle obscure. I find it rather difficult subject to elaborate, and being so general, it may have been indefinite. Still, I trust it may have fulfilled its object, which was briefly as follows. In the first place, to indicate to you the necessity of keeping separate in your mind the cerebrospinal system and the sympathetic system. Remember that you cannot separate these entirely, but look for symptoms from one and look for symptoms from the other. One is a cerebrospinal view and the other is a sympathetic. You do not really find them so separated in your practice. Second, to impress with the importance of diagnosis based according to the centers affected. Third, to teach you not to confound incidentals with essentials, not to mix mere symptoms with causes of disease. I thought I could thus indicate to you the osteopathic point of view, the osteopathic habit of mind in looking at disease. So again, functional anatomy as classification for reality. The observation that in reality you can't separate things out, but you can think about them as separate. So he's essentially suggesting cerebrospinous signs look for those, and then if a sign looks more cerebrospinous, consider it that way. If a sign looks more sympathetic, look at it that way. I think the intention or the implicit connection there is you'll treat the person differently or physically interface with them differently, but he's saying you really can't separate them. The reality of the functional anatomy is that you actually can't necessarily separate them if you're working from the outside. They both exist in similar physical locations, and your access points to them are essentially non-existent or similar, right? So you can't actually touch the cord or the sympathetic nervous system, but you can do things from the outside that should ideally impact them. The other deal, third, to teach you not to confound incidentals with essentials, not to mix mere symptoms with causes of disease. So he's telling you to reason from symptom back to cause, but don't act like the symptom is the cause. So that's somewhat reasonable. It could be stated more clearly, but at the time I think it would have made enough sense when being delivered in this fashion. The deal there, though, is going from the periphery back to the center. So to go from the symptom to the cause. That can be interpreted as go from the periphery of the body back to the spinal portion, or the cerebrospinal portion, or the sympathetic portion in physical location. That can also be thought of as just working backwards from supposed symptom to supposed cause. So acknowledging the obscure nature of a real patient interface, but telling you to segregate them. So it's the individual empiricism is asking you to be inductive, to pay attention to the patient, whereas the other portion is asking you to import ideas in this way, to be somewhat rigid about it. So you're again getting competing epistemologies or competing ways to create knowledge within that patient interface. So continuing with the lecture notes from Dr. Hazzard, or Hazzard, Charles Hazzard DO, however you prefer to note that. There's a certain amount of hair splitting done over the terms desensitization and stimulation. Their significance I will take up later, but always bear in mind that your first point must be to relax contracted muscles if you find them. If you do not, your work should be directed towards reaching the deeper structures mechanically and securing an equal distribution of nerve force. If there are contractions, no matter what your final treatment is to be, you must get rid of those contractions first. While the patient is upon his face, there is an important effect which we get upon the spine itself. Of course, we cannot separate this really in our practice. That is, the work along the spine has its effect upon the body according to the centers reached. Right? So that's fairly important. He's saying that in reality, when you're working on the patient, he's talking about a prone patient, so their stomach or their abdomen or their front is on the table, that you can have more direct access to the vertebral column, or you can use the analog of spine being held in the vertebral column. He's saying that if you find contracted muscles, soften them up. If you don't find contracted muscles and you have reason to believe that you should be treating the area, then go deeper. To go to a deeper structure, essentially what you're looking at is working in the area and creating motion. That's the implication. And he's saying regardless of what's going on, those motions will reach whatever is the problem. So he's saying get the movement back, and whatever the problem is will sort itself out, is essentially what is being pointed at here. So this is being more inductive. This is being more observant of the patient. You could call this a bottom-up approach. So as far as cognitive processing, it's the sensation first, the external sensation, and interfacing with that, as opposed to the thought first, or the top-down processing, or being a little bit more deductive. But he's saying, no matter what's going on, find the contraction. You don't find a contraction, move the thing anyways, because you have a reason to be there, and whatever is going on will sort itself out. He then goes on, and I'm not going to read everything, but to talk about ways of moving the vertebral bones, right? So springing the spines. It says, when they're on their face, grab an arm, pull it way back. It'll raise the ribs and it'll move the spine because the arm is connected in multiple ways to the thoracic cage, which will then pull on the ribs. It'll move the ribs. That'll move the spine because they're all connected. And he's saying that motion in and of itself, because of the conceptual center, so the top-down processing, the place that there should be a problem because of the symptom, just wiggle the arm really hard, move the spine, there you go. He also talks about getting both arms overhead. But the assumption there is that my classification system through functional anatomy notes a symptom, I carry the concept back to the center or to where I think the cause would be. Whether I find a motion problem with it or not, move it anyways, it should sort itself out. So functional anatomy as your classification system for reality, as well as essentially recognizing the uncertainty of the situation. So the obscure nature of things that you can't necessarily predict what this is going to work on or how it's going to work, but you can just do it anyways and it's going to work. So he's acknowledging the obscure nature, which would be acknowledging the uncertainty in these situations, but being very certain anyways. So that's the uncertain, or high degrees of certainty in uncertain situations. The uncertainty is acknowledged here, but being quite certain while doing it. So turning to a quote about rheumatism, the various forms of rheumatism are among the most frequent cases that the osteopath is called upon to treat. The fact that many of these cases have become long-standing chronic cases makes the average case of rheumatism somewhat difficult to handle and slow to cure. Very serious cases of deformity resulting from the disease present themselves for treatment. Frequently parts are dislocated, e.g. hip, knee, lower jaw, etc., simply in the progress of the disease. I've had several such cases. One case was of a man in this town who had been affected with rheumatism for some years, but one day he went uptown and while walking, his hip became dislocated. It shows you the drawing power of contraction in disease. I've seen more than one case where the lower jaw had been dislocated from the same reason. Joints become enlarged by growth of tissues, the synovial membranes are destroyed, and chalky deposits are formed in the joints. One of the most frequent phenomena you will witness in connection with rheumatism is the enlargement of the joints. For the reason that these cases, in the majority of instances, become chronic and this chalky deposit is formed. Consequently, it becomes one of the main points in the diagnosis of rheumatism. So he's telling you how you diagnose rheumatism or how you identify it. It's the enlargement. So when we think about rheumatism today, we're thinking about something that is known to be autoimmune. At the time, essentially, it would have been enlarged and inflamed joints. So if you've seen an enlarged and inflamed joint, you can think a bunch of things about it, especially from the outside at this time. So rheumatism is not an equal term in this time as it is to today. So you need to be careful with that when reading it. Hence, it is not strange that the osteopath frequently finds himself confronted by cases, certain features of which are beyond his skill, while at best they as a whole are slow and unsatisfactory. It is rare, however, that the osteopath cannot afford immediate relief from pain in any case of rheumatism, and almost without exception, cases coming under his care are greatly benefited in most particulars. So, something to note here is he's talking about chronic cases that you're not going to be able to cure. He's saying these joints are changed, you're not going to be able to cure them, but you're going to be able to treat the patient and give them some form of relief. So there is admission here that there are some things that the osteopath can't cure, but can have a positive effect on, at least on the subjective level, because the pain is much more a subjective deal. Now, injecting the concept of pain being more subjective than objective is a newer concept. It would not have existed in that way at the time that this was written. But the important thing here is the nature of the case, the nature of how he's telling you to diagnose it. He's saying if the joint is notably enlarged, that's rheumatism, right? So you're getting an understanding that something that may not necessarily be rheumatic in its nature, it could be osteoarthritic and, over time. However, I think in most cases, it is fair to say with our understanding now that most enlarged joints would be considered rheumatic, but he's got an external diagnostic, enlarged joints with lack of motion and pain, and he's associating that with essentially what would be autopsy reports. They've gone in and seen these chalky formations. So he's taking two things and bringing them together, sounding like a positivist. However, we can understand now that this really is more about a constructivist kind of worldview. This is what he's seen, and he's seen in many cases that you can relieve the symptomatology. So also the fact that it takes a long time, you're not going to cure it. So he's acknowledging more accurately the nature of what happens in certain cases. You can't fix them, but you can make them feel a little different. So looking at a quote from the lecture notes with respect to a virus, the lecturer is talking about influenza, catarrh, and cold. Now I don't know if I'm pronouncing catarrh properly. I may or I may not, so I will essentially each time note that I'm probably not pronouncing it properly. These three maladies are somewhat similar in pathology. They frequently are presented to the osteopath for treatment, and such treatment is, as a rule, in the highest degree successful. The treatment for influenza and for the condition commonly known as cold are almost identical, while that for catarrh is, as far as it goes, similar. If I remember right, catarrh is kind of, if I remember properly, a lot of it is accumulation of mucus. Hence, these subjects may be conveniently considered in the same lecture. The fact that all may depend on the same agency for their production, at least to some extent, namely exposure, and the fact that in all the main pathological facts are congestion of blood in certain parts of the body, the tightening of muscles and ligaments, and the aberration of nerve function consequent to these conditions make them especially interesting to the osteopath and especially amenable to his treatment. So just noting that in all three of these, that I would say he's probably going a step too far, but he's saying you notice contraction, which means that the blood isn't moving as well. Now that we can understand today that those things may not be equal, so that's an uncertain thing, but he's being quite certain about it, that because of the contraction, the blood's definitely moving slower. On the venous side, it may be moving slower in a comparative sense. However, on the arterial side, it's probably moving almost as normal, probably. All right. Go back to the quote. Influenza, commonly known as La Grippe, is called also catarrhal fever, and epidemic catarrh is described as an acute infectious epidemic disease marked by febrile symptoms and usually complicated with other serious affections, being followed by sequelae that are frequently distressing and severe in a marked degree, such as progressive muscular atrophy, various forms of paralysis, and spinal trouble. There is one patient here at present suffering locomotor ataxia and progressive muscular atrophy. He tells me that he had 4 or 5 different attacks of influenza. I think that his disease may have developed from these repeated attacks of influenza with the attending nervous symptoms leading to these serious results. It is not at all surprising that such serious results should follow when you come to consider that these nervous distributions or disturbances reach far enough to alter the state of nerve centers to a very marked degree. So you're seeing a patient report. I had 4 or 5 attacks of the flu. That may or may not be true, but that's the report, so you have to take that with a grain of salt. And then to say that the direct results of having those 4 or 5 bouts of the flu has led to severe atrophy. At the time, that would have made enough sense because the report and the finding match in the worldview or in the ontology or the classification system. However, severe, I would think that it would be somewhat rare under today's circumstances, first of all, to see somebody who had 4 or 5 bouts of the flu, maybe in quick succession or however long, and then be able to identify that as the cause of major atrophy. The major atrophy may be some other disease, but because of timing and the ability to identify things, you're connecting them. So I wouldn't take something like this as a report to put a lot of weight in. This is what he's seen from the reports of multiple bouts of the flu. You don't know if it was the flu. He doesn't know if it was his flu. He's just putting these things together. But the nature of multiple viral infections leading to a fair amount of muscular contraction, I think that's a fair observation, and maybe you could provide some relief to people in those situations. But we understand viral transmission a little bit better, so maybe our interface should change because we understand the transmission of the virus a little bit better. But the thing to note, positivist claim, high degree of certainty in uncertain situation, functional anatomy being the key to interpreting reality, and then it's really all constructivist as far as the epistemology. So we have that inconsistent epistemology. We also have something consistent with Barber of making a positivist claim from a constructivist point of view. So still in the lecture notes, we have our quote that spans 2 pages, which is why you see the break in the JPEG that we have on the slide. Whereas the physician halts often in contemplation of the cellular pathology, assigning for such conditions various causes, external or internal, the osteopath regarding cellular pathology as secondary attends to the mechanical regulation of all parts of the body related to the affected part. He often finds the sole cause in disarrangement of the mechanism, or he may find causes external or internal, as does the physician. In the latter case, there may yet be mechanical causes responsible for weakening of the tissues and the invasion by the disease. If no derangement of structure is found, as is sometimes the case, the osteopath devotes his effort to controlling the condition of the system by manipulation of nerve supplies, e.g. in a germ disease. So, noting a difference between, this is essentially a quote noting the difference between an allopathic physician and an osteopathic one. The osteopath considers some things kind of secondary. How did he say it? Osteopathic regarding cellular pathology as secondary, so he's not as interested in the cell. He does note that there are times when you find disease processes as maybe being more of an external cause, but when there's an external cause, he's saying we'll often find a mechanical derangement. However, there are times when we don't. So he's saying it's not always the mechanical derangement that causes the disease process, but when we don't find the mechanical derangement, we go to the nerve centers that we think we should go to and we manipulate them, and that's how we help the patient. Moving back into the quote, Brunton divides drugs into 2 kinds: protoplasmic poisons, which destroy all kinds of protoplasm, drugs which seem to have more or less affinity for variously differentiated protoplasms. These drugs act always upon the protoplasm, which is the physical basis of life. The osteopath secures the integrity of this protoplasm by controlling the quality or the flow of blood. So the thing to note here that is at least of some interest is that the view of reality, so they're showing a bifurcation in the view of reality where they're claiming that the allopathic physician views the cell as the basis of how things are going to work or not work, whereas the osteopathic practitioner is saying it's the host, or maybe the body as a whole, primarily focusing on blood flow. Now that carries the underlying assumption that the methods that they use definitely control blood flow. I think in today's world we can understand that the methods of an osteopathic practitioner, if they do anything to blood flow, it is for a very short period of time and locally, because especially arterial flow is locally auto-regulated. There are central mechanisms that control the caliber of vessels body-wide. However, the actual fluctuations in how blood moves is much more local. So it is unlikely that the certain claim that we're definitely controlling the blood flow stands up as honestly as they would have liked it to, but this is where they're showing the bifurcation, right? So showing that their belief, so the axiology, the value of functional anatomy, individual empiricism, and then the ontology of functional anatomy being the number one thing. So continuing on with the concept of comparison between the allopathic world and the osteopathic world, one marked feature of medicine of the present day is that in spite of the progress made, there's a widespread and increasing dissatisfaction with its results, both in the profession and outside, and a constant tendency to turn to new methods. So this is echoing Barber a little bit, saying our patients think we're awesome, right? So at the time that this was written, there was still a fair amount of heroic medicine. The understanding of pharmacy or pharmacology was not the best. It was early on, and there was definitely a lot of harm coming through the allopathic methodology. So that's a fair thing, saying that the general public had fear of physicians as they stood at the time, fear of their methods. So people were looking elsewhere because the harm that was caused was apparent. So it's kind of turning back to the subjective patient report and the value on the subjective patient. Well, we're awesome because they don't like the other people, right? So they're turning to us because they don't like the allopathic physician. So it's more of like a negative identity formation claim where we're awesome because nobody likes you, right? So that's an interesting thing, but it axiologically shows the value placed on the patient preference. So turning to the practice and applied therapeutics, the first quote we get there is essentially setting up how the knowledge was built. So this is the epistemological setup. Again, understanding that the term epistemology wouldn't have necessarily been used by these people at this time, but we're using it to constrain our analysis. By the use of these many case reports, there is established a foundation of actual fact and experience for this work. Theory is of value and is assigned its proper place here, but the facts shown in the case reports have been demonstrated by actual work. Osteopaths in all parts of the field, whence these reports are drawn, they are arguments which will do much towards convincing a prospective patient. They likewise give to the practitioner the value of others' experience. Much care has been given to the analysis of lesions presented by reports and to the pointing out of the lesions which may be expected as causes of disease. So, saying established fact, it's built on case reports, so you have to trust that those case reports are accurate, that they're telling the most appropriate observational framing of the facts as they presented themselves, that there was no messing around with them, that nothing was done to make them look sunny and positive. So you have to trust that. Also, case reports are understood to be of less value than something that's observed in a more stringent way. So, especially in a positivistic view. So this is a positivist claim saying, hey, we looked around at a bunch of case reports, this is what we found, so this is steady. But he's telling you it's case reports. So he's telling you that it's more of a constructivist thing. These truths depend on who wrote the case reports. It's also saying the lesions that can be expected to be the cause. He's not telling you that they're definitely the cause, they can be expected to be the cause. So the acknowledgement of the obscure nature of this, the acknowledgement of the uncertainty, but being certain anyway. So that's the high degree of certainty in uncertain circumstances. These facts explain why lower spinal lesion is so often found by the osteopath to be the cause of motor derangement of the bladder. A good illustration of this is seen in the lack of motor control in enuresis, due as a rule to low lesions. Reference to the case reports above will show that 6 of the 7 cases of enuresis presented a lumbar and sacral lesion. These anatomical facts underlie osteopathic theory of renal disease. They form a foundation for truth for osteopathic procedure. Lesion to these various important nerve supplies at their origin along the spine must produce renal disturbance in kind, and this disturbance can be righted only by correction of the anatomical derangement responsible for them. So The term fact, this is established by these case reports. So he's essentially saying, we looked these over and they have these findings consistently. There's no reporting of, they checked other things, they checked other possible ways that these problems with enuresis could have occurred. They didn't check through the allopathic lens, they didn't check through the homeopathic lens, they didn't check through any other lenses. They just said, we had these problems that presented, we went ahead, we checked the spine, we checked in our viewpoint, and we found these things. So that's more of a correlational claim or a temporal correlation. They don't know if those problems were there 20 years ago. They don't know if the person had those lack of motion 30 years ago, if it just happened yesterday. There's no accounting for time frame. There's no level of uncertainty that, these show up at the same time, but we don't know how they're related or how related they are. So very firm, so high degree of certainty in uncertain circumstances. The ontological framing of functional anatomy. So, the lower lesions are leading to these problems with the bladder. Now, I don't know the degree to which the functional anatomical understanding was there of essentially S2 to S4 in relation to the internal and external urethral sphincters or any of those things, but the way that the nervous system is set up for control, because you are more likely to see bladder dysfunction when there's lower spinal dysfunction. That lower spinal dysfunction in an adult could actually be higher because the spinal cord doesn't segment equal to the vertebral column. So the conus medullaris, this is more functional anatomy talk as to why you may find things in other places. If this holds true, if the functional anatomy as your interpretation of reality holds true, the conus medullaris can be from T12, so the end of the spinal cord can end at T12 or as low as L3 in some cases, but usually it's about L2, which means that the cord segment for the bottom of the sacrum and the coccygeal segments actually can live as high as T12 or as low as L3. So you can have a problem all the way up there leading to this, but he's saying that because of where the nerves exit, this is what we're seeing, right? So the functional anatomical classification of reality as very important, high degree of certainty in uncertain circumstances, the themes continue to show themselves stable. So continuing with practice and applied therapeutics quotes, as a rule, local treatment is secondary to that done upon the spinal or pelvic lesion, which is usually the real cause of those conditions which require local treatment. So this is establishing hierarchy, saying that, at least from Hazzard's point of view, or the point of view of the profession very early on, that the central problem, so the problem that is closer to or directly upon the vertebral column or the pelvic region, because of the exiting of the nerves, as well as the fact that those control blood vessels more centrally, that those are the real problem. So you have a problem with your index finger, you might have to treat the index finger, but you have to treat the neck because the neck is more important than the index finger. So he's essentially setting up the hierarchy here in writing of the primacy of the vertebral column and the pelvis as far as the generation of problems. So here we have, again, juxtaposition between the osteopathic and the allopathic concepts. Osler's statement that the cause of disease is probably microbic is a confession that the real cause is not known. We hold the true cause to be anatomical lesions as described. The fact that the disease is often the sequel of catching cold is suggestive from an osteopathic point of view. The contraction of muscles and tissues from exposure may be sufficient lesion, or may produce actual bony luxations by drawing parts out of place. The further fact that the subjects of spinal curvature are prone to disease is a confirmation of the osteopathic idea, making bony lesions the cause. So comparing the osteopathic and allopathic worlds. This holds to the theme that there is some prejudice against existing healthcare systems. Now, this isn't a direct prejudice, this isn't necessarily very harsh, but it is comparative at least, so we're more awesome than you is the essential view. And he's relying on observational findings without ruling other things out. So as far as the scientific process is concerned, and this isn't an idea that came out until close to the 1950s, but for something to be acknowledged as true or useful, you have to attempt to disprove it. So he's trying to prove his idea. The term that you'll hear often in common conversation is a confirmation bias. That's a description of a normal cognitive process. It's a mistake that you don't know you're making. You're looking for proof of what you believe. To be more rigorous, and again, this is not a concept that took good form until I think the 1950s, but you should try to disprove yourself. It may have actually been earlier than that, because the gentleman's name that did most of that work or influenced most of those ideas is Karl Popper. It may have been earlier than the 50s, but the 50s is what pops into my head, right? So acknowledging my degree of uncertainty with the specific thing that I'm claiming. But you can trace it to Karl Popper. You should try to prove your concept wrong. So if your concept fails to be proven wrong over and over and over again, you increase the level of confidence that it is correct. This is not how he's going about this. He's saying, oh, it's microbes. So also, William Osler says it's microbes. That's just a confession that we're awesome, right? So you've got to be careful with something like that. So this is evidence that there is some degree of prejudice between pre-existing healthcare modes, and saying that functional anatomy is the best way to classify reality. And it's when functional anatomy is perverted that we see the problems. But he's already admitted that there are times when there are problems and you can't find an issue with the functional anatomy. So because you didn't find the issue, you just go to the areas that you need to manipulate them, and then the person gets better, right? So that could be a superficial case to say, well, you didn't find the problem that you thought you found. You went to the area and you did something. Are you sure that you doing something didn't just happen at the same time that the person was going to get better anyways? In this viewpoint, you'd say, no, it was definitely because I did that thing. But realistically, it could have just been the fact that you were there at the same time they were going to get better anyways, because your theory doesn't hold true. You didn't find the mechanical problem, going back to some concepts discussed earlier in this examination. But he's saying, again, functional anatomy, number one, that's the big deal, right? So the theme of the prejudice between professions, the theme of the classification of reality, the ontology being functional anatomy appear again. So after going through these quotes from Charles Hazzard, we want to pose the question if the themes that were previously noted with Dr. Still and with Elmer Barber seem to hold consistent. And it would seem that they generally do. The details here, so you saw some of the disagreement in writing between Still and Barber. Still says it's bones, Barber more so says it's the other tissues. It would seem that Hazzard's somewhere in between those, right? That's what it would seem. No consistent epistemology. As similar with Barber, Hazzard seems to make a lot of positivistic claims that really are constructivist, so the understanding of how to constrain the building of knowledge doesn't necessarily seem to be as well fleshed out. That could be more indicative of the time, but because this wasn't a concept that was well developed then. But we can still identify that there is no consistent epistemology. The ontology is still focused on functional anatomy, essentially as displaying the laws of nature. It's the most important thing that we see over and over again. High degrees of certainty in uncertain circumstances, and again, the general prejudice against other healthcare practices. Barber was the least prejudiced. He said positive things. Hazzard's a little bit more prejudiced, but not in a rough way. Now, the new thing here, so the new thing with Barber seems to be the importance of the patient report, and they like us. They think we're awesome. They don't like the docs as much. or they don't like the allopathic physicians as much. That holds true. Hazzard notes that. The other thing that seems to be new is, now it doesn't mean that it was new in the profession, it means it's new in our textual analysis, in the texts that we're looking at. The new theme here, and it's a minor theme, seems to be the centrality of the spinal or pelvic lesion. So I only treat your finger because, it's there, right? So problem with the index finger, I treat the index finger, but that's not really the big deal. I need to treat the neck, something along those lines. So that's a minor feature, but it does set something up that, in personal experience, this isn't necessarily part of the analysis of the text, but I've heard varying beliefs expressed about how important the vertebral column of the spinal cord is, and the pelvis, the pelvis is absolutely this huge deal. And then I've heard people who do not necessarily agree with that, and I've heard shades along a spectrum of variation. But that is the earliest mention that we've pulled out of the text that we've examined that sets that concept up. It's not necessarily a major player, but it's there. So overall, the themes seem to be holding fairly stable from Dr. Still to Barber to Hazzard, keeping in mind that both Barber and Hazzard were very early students, so you would expect that they would be thematically similar.